So here's a GPM way to start medications. I'd like you to try this medication knowing that whether it will help is not certain, and that you will need to help me assess whether it's effective. It'll be helpful for you to read as much as possible and to monitor whether you see improvements in the symptoms that we are trying to suppress. Will you do this? One of the recurrent themes throughout the day is the collaboration of the patient's role as an active participant in their own care. In every phase of all of the treatment, you start out by getting the patient involved and taking care of their own problems. You almost never do anything unilaterally. I won't dwell on this. It's just factual. There's a body of knowledge about the role of medications. It's quite discreet. There are no approved medications for borderline personality disorder. They're not likely to be. The pharmaceutical industry has generally stayed away from showing much interest in experimenting with possible drugs for this group of patients, ostensibly because they're worried about the liability issues. The patients will overdose or kill themselves, and that there will be liability, and they don't want to experiment with medications on such a litigious population. I think that is a relatively shallow reasoning, and that the real reason starts within the field of psychiatry itself, where the practitioners in psychiatry who are interested primarily in pharmacotherapies don't want to work with borderline patients, and they don't want to spend the time with them that doing medication trials require. As I said earlier, I think that the growing knowledge about the role of neurohormones in the brain chemistry of people with borderline personality disorder is a horizon which is going to invite a great deal more research in the next generation and may give way to a whole new sector of drugs. There hasn't been any new drug in the whole field of psychiatry for any disorder for a long time now. There have been variations on old drugs, but nothing new. And the psychopharm industry has really withdrawn doing much research in this area. Just another thing you probably already know, but if you have a borderline patient who's on a lot of medications, this is almost always a testimonial to the fact they're not working. So that when you have a patient who comes to your care with many medications, that doesn't mean you have to worry about withdrawing the medications. It means this is a person you probably should try to withdraw from medications. The medications have harmful effects, and they are not likely to be having much positive effect when a patient's on more than one and the patient is not gotten better. Strategies to manage medications, then we'll take our break. Temper high expectations. Emphasize the need for collaboration. And stress the necessity for responsible usage to evaluate effectiveness. Don't be proactive. Don't go out looking to find the medication which the patient wants. If the patient has severe symptom problems, then medications may be helpful, and you should be responsive to this possibility. If a patient has only modest symptom problems, don't suggest it. Don't you bring it up. And the algorithm about choice of medications generally follows one of the symptom problems, the primary symptom problems that the borderline patient presents is what should guide your decision about what medication to use. I think we'll take a break at this point. All right. You know, you're getting better as the day goes on, and I want to take advantage of that. So before I move ahead with this discussion about medications, this is a nice opportunity to ask some of those questions or make those comments that you've sat on all day. So comments or questions. What you always wanted to say and never thought you would. Just one, and then I'll go on. Just one. No, you're just scratching your head. Yes.
It's perhaps a bit offline according to medication, but I was thinking about the therapeutic alliance you were talking about in the starting phase.
Yes.
And I was thinking, are there actually very many publications about the therapeutic process, alliance, etc., for borderline patients?
Yes. I've got to be careful here because while I've read almost all of them, I don't have them synthesized or the front of my mind. But for example, with respect to medications, there have been studies which show the medications can be used to improve the alliance with the caretaker. I think there's nothing magical about that. That is, a patient are, in MBT language, rather teleological. Somebody does something to indicate that they want to help relieve their distress. The patient will feel, this is somebody who cares about me. And if you don't do something concrete, they may have a hard time believing that you care about them. So it's that. Now, it's also true that sometimes medications can provide real symptom relief. And that relief is something patients will be grateful for. And so that too, quite aside from the intention and the fact that you're doing something, is another reason why it can facilitate building an alliance. No, there's a literature about it. I made reference to it in passing about, this was many years ago, the study that where we showed it takes, I think, like 6 weeks for patients and therapists to agree about roles and goals, about 3 months for them to develop what's called a relational alliance, where they have some mutual, the therapist feels they understand the patient, and the patient feels that they can trust the therapist's intentions. And then this working alliance, they sort of high grade the Mercedes of alliances, where you're working together side by side on common goals, and that often takes more than a year. Now that was done, that study, we've completed that in about 1993, something like that. And the therapists that we're using were not particularly experienced. It was before evidence-based treatments. And I believe that the whole thing can be expedited and goes more quickly now because we know more. All this stuff about psychoeducation, for instance, is very powerful in alliance building. Okay, so back to medications. We have a video. Now this is a therapist and a patient who've worked together quite a while. So you have to see it in that context. And from that context, it's interesting because you do things. When you get to know a patient and a patient gets to know you, you sort of leave the textbook and you have a language together which is sort of built on past experience. And so, for instance, this video, the people have watched and said, oh, the therapist is so sarcastic. Well, this is the kind of exchange that you develop with patients. It's not something anybody would advertise or encourage, but it is the relationships form, and you get your own certain ways of relating to each other, and that it illustrates that very nicely. So, all set back there? Oz is back here.
So I wanted to talk about my medications because I just don't feel like they're working.
Oh, what have you noticed?
Well, I am not sleeping and I feel like shit.
I'm really sorry to hear that, but I can't say I'm too surprised.
Why?
Well, first, you've really always told me that the medications aren't very helpful. But second, I know that there are a lot of reasons that you might feel really badly. Unless, of course, your mother has suddenly apologized and now you enjoy washing all those dishes.
Well, you don't really need to be so sarcastic.
Well, all I'm saying is that there's some inherent limitations in what you can expect from the medication.
So you're taking away my medications?
No, but let's think about some changes.
So, new medications?
No, I wasn't thinking so much of adding new medications as I was of taking ones away that haven't been really helpful.
So, because of side effects or whatever, I don't get it.
Well, good, you've been listening. Specifically, I was thinking about decreasing the Prozac. You've said that it hasn't been very helpful to you, and now research supports that conclusion.
Well, I've been taking Prozac a long time. And I guess I just don't feel comfortable with not taking it anymore.
Wow, well, you would make it really easy for me to say, okay, let's just stay with it.
Well, you're trying to take away my medications, and I'm telling you that I still feel like shit.
You know how I feel about just using medications to manage your emotions.
Well, what about a bargain? I'll take the Prozac for 6 more weeks, and then I'll start my autobiography.
Well, I've been waiting for that one for a long time, but I'm pretty clear that this is what's best for you, so I'll go with this for now. But let's now focus on the problem that you're having with your mother.
I don't really want to talk about that either.
Well, avoiding difficult subjects isn't really what's best for you. But now it's my turn to strike a bargain with you. I'll let go of this topic for now, but you can start telling me about your efforts to find a new job.
Jeez, that's even worse, but you're so persistent.
Well, what about that?
Yeah. Get a job. So you see this sort of bargaining that they're doing with each other. It's got a, it's okay. It's okay. They're respectful of each other, and they work out compromises. And you put off till tomorrow what would be standoff or a dead end today, and if it were, it's all right. It's okay. There's nothing urgent, but you don't give up doing the right thing. Needs to talk about her mother, doesn't want to do that. Well, we'll talk about something else. Oop, doesn't want to do that. Well, what about that? You know, it's just good, basic therapy approach with borderline patients who generally don't want to talk about things that upset them. And you don't push it too hard, but you don't go away. Other thoughts about this video? It's very typical, this thing about patient says, I feel like shit, but don't take away my medicines. Well, you feel like shit when you tell me the medicines don't work, but you don't want to go off of them. There's no urgency about getting people off meds, but the meds oftentimes don't do any good. I think that the guidelines from, I can't remember the acronym, the English guidelines, PRIT? Nice, yeah. Say that borderline patients really, there's no very convincing evidence that borderline patients should be treated with any medications. I think that goes too strong. Because it ignores the fact that borderline patients can be improved somewhat, and that there is evidence that they can be helped with them. It's just not very impressive, but there hasn't been that much research either. So you have to be pragmatic about them. And in the United States, it's now almost impossible to see a borderline patient who gets to a hospital who hasn't been put on medicine already. Most of the prescription of psychoactive drugs in the United States is not done by psychiatrists, it's done by primary care physicians and internal medicine people who are, and RNs, family clinicians. There's a large number of non-psychiatrists who initiate most medication trials, medications. And so as mental health professionals, you have to be prepared to deal with this issue. It's not something that's going to go away, at least in our country. And you're often stuck with this problem where you believe, and even the patient will say, that medicines haven't helped, but they will be very resistant to going off of them. So it's not an uncommon issue at all. And just persistence, patience, recognition that going off of an SSRI, in this case Prozac, is often very troubling. It's a very disturbing psychologically, physical experience to wean yourself from those medications once you get on them. And so there's a real reasons why patients are reluctant to get off of them, and real reasons why we should be reluctant to get them on them without good reason. So, I already talked about this, not being proactive. Oh, I'm going backwards. Yeah, so here's an algorithm, which is sort of an update from the one that was in the American Psychiatric Association guidelines published in 2001. What it says is that if patient's has mild symptoms and doesn't want meds, don't offer them. If they want meds and you feel like it might be helpful to them and might help build an alliance, SSRIs are usually the first start because there's few side effects. But as you saw in this example, you have to be aware that after a long time, it's difficult to get people off of them once they get on them. If a person has more severe symptoms and their problems are largely affective, you start with mood stabilizers. If their problems are primarily impulsivity and anger, you start with antipsychotics or mood stabilizers. And if they have primarily cognitive perceptual problems like dissociation or paranoid ideas, Then you start with antipsychotics. So they're general guidelines. They differ from those of a decade ago in that SSRIs, which were more heavily featured 10 years ago, now recede as something that have more of a placebo action. The evidence about their actual effectiveness, as she told the patient in this video, is very mixed and not very convincing. The antipsychotics and mood stabilizers have more evidence to support their usefulness. And here's a sort of breakdown by several analyses of what classes of medications work for what symptoms. Of particular interest and importance here is that the depression, there are very few medications which have much benefit for depression. And yet that, because borderline patients frequently complain about depression, it is frequently the symptom complex which medications are targeted to improve. Again, this is very good knowledge for you all to know that as depressed as the borderline patient may be, and as logical as it would seem to give them antidepressants, this is a class of medications which is not particularly unlikely to be helpful with that symptom complex. They are more apt to have a response to mood stabilizers and antipsychotics, but even there, the evidence is not very good. Where you have more evidence for effectiveness is in the anger impulsivity. Mood stabilizers are the best of the lot. And with the cognitive perceptual things, antipsychotics are the best of the lot. This last column, I think it's supposed to be self-injurious behavior at the top rather than SE. I'm not sure. I think that got added by somebody else. In general, you can use medications for somebody who's acutely agitated and anxious and maybe acutely suicidal to diminish their agitation and to help calm them. But that should not be a long-term strategy. It should be done for a day or two at most, not as a sustained strategy. There's nothing that's a sustained strategy in the medication world for self-injurious behavior or suicidality. Benzodiazepines are habit-forming, sometimes disinhibited as a class of medications. These are the ones that are relatively contraindicated. Borderline patients like them, and they often, once they get on them, really don't want to get off of them. But when you have double-blind studies, what it shows is that they get worse even though they like them the best of any class of medications. So it's best to stay away from them. You can use them for crises sort of in an anxiolytic way, but take them off of them after a few days if you are going to use them. Mood stabilizers have the broadest range of effectiveness, but it's not very dramatic, and it certainly isn't consistent. And antipsychotics, again, they have some breadth in their effectiveness. They're often sedating in ways which can be helpful, but you worry about side effects. So let me talk about comorbidity now. This is a complicated slide. Just to look at the first one here. When major depression co-occurs with borderline personality disorder, it may have a negative effect on BPD's course. BPD will definitely have a negative effect on the other disorders, in this case, major depression's course. with respect to bipolar disorder. When bipolar disorder is present, it has very minimal effect on the course of bipolar disorder. And likewise, and this is very surprising, borderline personality disorder has very little effect on the course of bipolar disorder. And this was really quite remarkable to me for several reasons. One, the overlap in symptoms in terms of mood problems and impulsivity problems suggested that these two disorders might be quite linked on some basic neurobiological basis. So the fact that they would behave so independently of each other is surprising. It's confirmed by the fact that borderline personality disorder does not co-aggregate in the relatives of people with bipolar disorder. People with bipolar disorder do not occur with much greater frequency in the relatives of people with borderline personality disorder. This, now, mind you, I don't know how much Norwegian psychiatry has been affected by it, but the United States is much affected by the idea of bipolar spectrum disorders. And the diagnoses of bipolar disorders have magnified like tenfold in the last 15 years, so especially in children. So that the bipolar diagnoses have become very popular in the United States. And Haga McKiskell for a long time has said that borderline personality disorder is really just an atypical form of bipolar disorder. But the evidence from both family studies and from the studies of longitudinal course confirm that it is actually quite independent. Very important, everybody should know that. It's counterintuitive, but it is clinically important. Anxiety disorders, borderline personality disorder, they don't affect borderline personality disorder very much, but borderline personality disorder has a very negative effect on anxiety disorders. You remember in that video with Carl, where she has her panic attacks, turns out that they're related to Carl's absence. So you can see how, in that example, if you can treat the borderline personality disorder, the cause of the anxiety about being alone, the likelihood of the anxiety attacks will decrease. But you're not going to be able to affect the cause of the panic attacks without paying attention to the interpersonal problems which generate it. Post-traumatic stress disorder, mutually harmful effects on each other's course. Substance abuse, mutually harmful effects on each other's course. Eating disorders, no effect, independent disorders. Surprising? Yes. Great. Yes.
Do you have any, how is the comorbidity with personality disorders and Asperger's syndrome?
Asperger's?
Yes.
Well, I don't know. I mean, on paper, you would think that insofar as Asperger's syndrome is one where there's not much emotionality and a lack of emotional responsivity, you would not think that there is much. The other side of that is that the borderline patients may have a inability to recognize feeling states in themselves and others, which would suggest some possible overlap. It may be coincidental, but it seems to me that we see a lot of patients with borderline personality disorder who have a parent with Asperger's. And that fits with the developmental model of mentalization, that the child of somebody whose caretaker has Asperger's disorder is unlikely to develop the kind of recognition of feeling states and the ability to communicate them or to read others accurately if they have a parent with Asperger's. But I don't know anything beyond that.
Continuing that thought, when I see female patients with their caps and their tattoos and their legs crossed in their chairs, like on your video, I immediately think of girls that I've treated with ADHD who grow up to be these very stigmatized, I mean, they stigmatize
Yes.
themselves, females. Do you
Yes.
see any connection?
Yes. I actually don't, I should know, but I don't know the research literature about that. But clinically, I have definitely known, I have one patient who was featured that. I mean, she had she was the third of 3 children. Her older sister and brother did fine in life. She had a learning disability and learned very early in life that the things that came easy for her siblings were very difficult for her. So she cultivated this style of getting her mother to do her work for her, which just made her more and more helpless and dependent and very resentful about a world that she felt was unfair. Now, mind you, that's all environmental. So there's nothing in that formulation which takes into consideration the genetic disposition. Nonetheless, she was a very difficult patient to get out of that into something more self-sufficient. She eventually did, and suffered the death of her parents without killing herself. But yeah. There is I believe, and I wish I knew, somebody else may know, but I think there's a higher frequency than usual of ADHD in people with borderline personality disorder than the general population. But I don't think it's much higher than it is with many other psychiatric disorders. I think ADHD is like a predisposing or moderating factor in development of depression and certainly bipolar II disorder, which has all the predispositions that borderline does and none that bipolar does. So it's this is very good. You're coming out. You're coming out. This is very good. And I can't wait for the discussion, which is going to come about half hour from now. Right? Okay. So, when you have borderline personality disorder co-occurring with one of these other major psychiatric disorders, how do you go about planning treatment? First one, major depression. This is, I think, clearly the most important one because it's the depression. 50% of borderline patients appear with co-occurring major depression. 70% have major depression during their lifetime. I think it's around 20% of people with major depression have co-occurring borderline personality disorder. They are never included in any of the drug studies for the antidepressants. They exclude borderline patients from those trials. And they're the major cause of treatment resistance in depression. But you never see it in the literature about treatment of depression because they deliberately never include borderline patients in those drug trials. That's another story. Depression. BPD is the primary. It will remit if borderline personality does. So if you treat the borderline right, the depression will go away. If you try to focus on the depression, the chances of you doing much with it are very limited. And instead, what you'll do is postpone the patient's access to treatments which might actually be effective. Bipolar disorder, if a patient's manic, no. Leave the borderline alone until the patient's not manic anymore. When they cease being manic, then You continue to treat them with the mood stabilizers as you would anybody else with bipolar disorder, but don't expect that the mood stabilizers are going to effectively treat the borderline personality disorder. You have to treat the borderline personality disorder too. They're two independent disorders, and they're not going to go away by treating one and not the other. Bipolar 2, that's the most interesting thing. If you look at the literature about bipolar 2, you see that bipolar 2 is a condition that does not respond very well to mood stabilizers, nor does it co-aggregate in families very strongly with bipolar 1. And the developmental histories of people who develop bipolar 2 disorder have a lot of rejection sensitivity, childhood trauma, early childhood separations, insecure attachments. Are we talking about borderline personality disorder? I got confused. It's a very interesting literature. It doesn't mean, to my mind, that bipolar 2 does not exist. I know it exists. I've seen it and I believe it. But it is much overdiagnosed for people who are actually borderline personality disorder. And the literature about bipolar 2 is so contaminated because they make no efforts to separate out people who have borderline personality disorder that they look almost the same on all these indices. General anxiety disorder and social phobia, borderline personality disorder is primary. You treat the borderline personality disorder, generalized anxiety, social phobia will remit if BPD does. PTSD, complex PTSD, you all know what that is. That's the early onset with severe childhood trauma. That's a disorder which rightly should be set apart. Such people are so innately distrustful, hypervigilant, that the kinds of challenges, the kinds of requests to take charge of your life that are important in treating borderline patients will be experienced by them as blaming, and it doesn't take into consideration that they have this consolidated and oftentimes very justified sense of themselves as victims, and you ask somebody with that psychology to take charge of their own life, and they'll just retreat and get worse. So that takes precedence. On the other hand, adult onset post-traumatic stress disorder, BPD probably predisposes the onset, and usually the treatment of the adult onset post-traumatic stress disorder will remit in the context of an ongoing treatment for the borderline personality disorder. It isn't like it simply goes away, but it needs to be integrated, that the clinicians who treat adult onset PTSD who have borderline patients need to encourage the patient, after they have developed more trust in you, to recall the experience and to express the feelings associated with the traumatic events. And they can do this. They're not going to do that early on. It takes time for them to have enough trust in you. I would say that there's two aspects of that. They have to have enough trust in their treatment team, and they have to have enough stability and support in their outside life. Then they can do that trauma work very satisfactorily with very big benefits for their welfare. Substance use, if it's dependency, a patient, then sobriety makes treatment of borderline possible. Abuse, probably concurrent treatment required. Anthony Bateman would tell you that most of the people in his MBT trials have had concurrent substance abuse, and he does not see that as a deterrent. We would say that It can be, and sometimes is, but he seems to have more good luck with more severely damaged people than we do. Antisocial, sometimes you can treat when antisocial and borderline appears, there's a real tension within the patient between that aspect of them that wants to use the treatment to exploit the secondary gains of being a patient, to avoid consequences which the treatment setting allows, to evoke sympathetic responses they wouldn't otherwise get, and the borderline part of them, which is really hungry for some kind of corrective relationship and has hopes that they could one day have a truly satisfying interpersonal or vocational life. So it's very conflicted and interface. And sometimes you can get on the good side of that or mobilize the better parts of that is the borderline parts of that person. But sometimes the secondary gain parts are too powerful. When the secondary gain parts of being a patient, then it can be harmful to other people in your milieu. And so you have to be very careful about the harmful effects that antisocial people can have on the other borderline patients if you are doing groups or in hospitals and things. Narcissistic, yes, but I would say narcissistic personality disorder is a more difficult personality disorder to treat. And it poses additional problems so that the borderline patient who's also narcissistic is harder to treat than the straightforward borderline person. Their entitlements, their sensitivity to being other than the best or getting all the attention is escalated. Their pickiness about who can treat them and who can't. There's lots of things about that combination which make them more difficult. Eating disorder, anorexia, no. Bulimia, probably, usually. Is that a hand? Oh, he's scratching his head. I saw that.
Why is not ADHD on that list?
Oh.
The overlap.
I don't know enough.
That's okay. Neither do I.
Well, I mean, somebody asked a question about that about 20 minutes ago, and it should be. I think I redid the slide once and had ADHD on it, but I keep redoing the slides, and sometimes there's things there that shouldn't be, and there's sometimes things that are missing. I don't remember. What I would say about it from my memory, which I would remind you, I am an aging gentleman, and I can't be held responsible for the lapses that.
There are two disorders quite common in ADHD, and that is borderline and antisocial. So I would just like to know something about the overlap.
Well, as I said earlier, I'm sensitive to the fact that the ADHD can be very significant, have a significant role in both causing BPD. I have also seen patients who look like they have borderline personality disorder who have been treated with Ritalin or some, what do you call it, the mood stimulant, who got rid of their borderline personality disorder. So, you know, it's a interface which is complex and goes both ways. I don't know what the statistics are. I think when they co-occur, you can and should give trials of the stimulants to see what they do, but be very cautious, because if the person's borderline, there's a real good chance they'll misuse those, either for self-medication purposes or sell them, because there's such a market for them. So, but I can't promise the next time I give this talk, but I'm going to get there. Thank you. That's it? Ron. Okay, I've reviewed this. Think about it. When borderline patients are depressed, they have lives that suck. That's a good explanation. Medications are not likely to be helpful. Psychoeducation helps. Talking to them about the fact that they have good reason to be depressed is a form of validation, which is very useful in getting treatment started. Comorbid anxiety. Borderline patients are inherently, their inherent temperament involves a lot of neuroticism. They're very anxious people. They have good reasons to be anxious. Meds are secondary, but it's more likely to be mood stabilizers, and anxiolytics are something that are not likely to be useful. Be cautious about their use. Psychoeducation, about the interpersonal sources of their anxiety, and the fact that they have borderline personality disorder in some ways is a better prognosis than having the anxiety disorder. Sobriety improves prognosis. If the person's dependent, we require them to be sober for 30, 60 days at least. If they, otherwise, you get them involved in 12-step programs, AA, okay. So here's some questions which I'll ask you. Do you think psychiatrists should find someone else to do the psychotherapy and case management rather than doing it themselves? You think that that's something you should actively seek out if you're a psychiatrist? How many would say yes? How many would say one? How many would say no? One. Oh, you are Norwegians. Is that what it is? I can't believe you don't have opinions on this. Okay. Well, within the GPM model, we're trying to encourage psychiatrists to take on more than just the medication management. But as I'll move into now, split treatments, there are advantages in having partners within treatments. And so there's no right or wrong answer. Should other mental health professionals recruit a psychiatrist to prescribe meds if their borderline patient is not on them? How many say yes? How many? I see these hands go like this. How many say no? I can't believe it. I can't, you gotta say no. I mean, meds aren't required for treating borderline patients. They can be helpful, but why go out of your way to add, At the end of the day, I hope that you'll be, when you go home, you'll say, well, I wish I would have said what I really think.